Good afternoon, ladies and gentlemen. Welcome to this Give Me 15 Minutes education program for medical professionals. My name is Jennifer Sirfas, and I am the CEO of the Sirfas Consulting Group. This presentation is covering what you need to know about ACO physician exclusivity. This is a live session which is being recorded on April 24th, 2013. Will be available for free through iTunes as a podcast or as a video archive with handouts on jensirfas.com. One quick legal note. None of the information contained in this presentation should be construed as legal advice. I encourage you to contact counsel if you have any questions regarding state or federal law that apply to the concepts covered in this session. At the end of this presentation, I will cover questions that were submitted during the live session and also prior to this recording. For live participants, please submit any questions that you have in the questions box, which appears on your screen. So with that, let's go ahead and get started. I have a number of issues to cover regarding the accountable care organizations, and I'll get into exactly what is an accountable care organization very briefly. I'll talk a little bit about the patient and physician attribution and some of the issues that are raised, what the recent FAQ clarification impacts are, and then the practical implications for medical practices. So let's get down to business. First, for those of you that are not familiar with the term accountable care organization, it is actually a term or just a acronym that is attributed to Elliot Fisher from Dartmouth. Also, Mark McClellan came up with this term, and so they are considered the grandfathers of the term. And the term was pulled into Public Law 111-148, which we now know as Obamacare, and specifically it describes what an ACO is and its delivery organization. To quote from the legislation, it is a shared savings program that promotes accountability for a patient population and coordinates items and services and encourages investment in infrastructure and designed care processes for high quality and efficient service delivery. Groups of providers or services and suppliers may work together to manage and coordinate care. So the entire concept of an ACO in many ways goes back to a long-standing belief that there's been out there and tested year after year about the fact that if you coordinate care for a patient population, you should actually be able to make things more efficient, and that there should be savings that are had on the again, overall life cycle of the patient care that you offer to that individual person or patient population. It does require some population aspects to it, and it's not something you can do for one patient. Instead, in many ways, this looks more like capitation back from our old HMO days. So what is the key aspects for an HMO, or excuse me, for an ACO? The reason that I want to pull this out and how it's different than other models, including the health maintenance organization model, really comes down to several key things. And personally, I look for a couple things in particular. The first one is clinical alignment. In an ACO, the physicians and medical professionals that are offering care need to be clinically integrated and need to be aligned on certain protocols and procedures. In many ways, there doesn't need to be one way of doing things. Instead, there needs to be maybe a suite of doing things, instead of normally what we see in medical practice where there's a bajillion different ways of doing a medical service. There isn't just one protocol. There also needs to be a defined patient population, and we'll get into this because this is actually one of the biggest issues. An ACO is going to treat a certain patient population. Usually it's geographically bound, and in the case of the Medicare or Pioneer ACOs, which are right now under a pilot process, but in that instance, it's actually defined by the age of the patient and their eligibility in Medicare. Also, care coordination. This is, of course, very key, is that, it's not just one physician that sees a patient in the hospital and then it's never followed up. Instead, that the primary care physician in many ways acts as not necessarily a gatekeeper, but instead acts, if you will, as the medical home and coordinates care with specialists. In this instance, the specialists are usually considered a wraparound network, and we'll get into a little bit about that. There needs to be shared savings. So as over a course of time there are fewer expensive medical services, those savings are then shared between the payer and the providers. There needs to be analytics, lots and lots of data, and then information exchange. So for instance, a primary care physician would know that their patient has just gone into the hospital. So there has to be information going back and forth between all of the various players, including the payers, the pharmacies, the home health clinics, the skilled nursing facility, and again, the physicians that are involved in the care. Some of the things I look for really comes down to having systems that are interoperable. Can they talk to one another? Do they have uniform clinical protocols? Do they have a patient roster that they actually pay attention to and reconcile? This is a really big thing that I saw in California, which really, in many ways, makes the capitation out there sustainable, is the fact that they really know who is where and what the services are that they're getting. They need to have near-time data, and this is one of the ongoing problems, and they need to provide a full spectrum of care. So it's not just, let's say, cardiology services. It needs to be all type of services for the patient. So what is this attribution problem, and why is this FAQ that I brought up so interesting? So the attribution problem is that in the legislation that came forward, again, this is part of the Accountable Care Act, also known as Obamacare, but in that law, it stipulated that there needed to be a defined patient population. And for you to define what that patient population is, you have to attribute the patients or the Medicare beneficiaries to an individual accountable care organization. So some of the things that we know is that, number one, CMS has come out and said that they are going to define the ACO and the individual providers that may not be employed by the ACO, but instead are rendering services as part of this group in this locality. It's by TIN, not by NPI. It's by their tax identification number, which is helpful. It's very helpful to know that. The thing, too, that they stipulated was that primary care physicians are exclusive to ACOs. Great. Makes sense that if primary care physicians are going with this one ACO, they can only work with that ACO and not multiples. Again, helpful, not necessarily great for primary care physicians, but helpful to understand that. So then the next question is, well, what about specialists? What about the cardiologists? What about the ENTs? What about orthopods in sports medicine? So what do we need to do in that area? Well, this is where, again, the volume of patients is a really big deal, because if you were mandated to be exclusive with one ACO, the big problem becomes, well, what if you only see 5% of your patients coming from that ACO, and if you pull together, let's say, 3 ACOs in the area, you're able to bring it up to 45% of the patient population. It becomes a sustainable model, especially when you may be discounting services to give better access. So if that's true, what happens if those specialists are giving quote-unquote primary care services? So going back and looking at obstetrics and gynecology or cardiology really becomes a major issue. So with CMS first came out and gave us some guidance, and this is in the Code of Federal Regulations. It's in 42 CFR 425.20. They stipulated that really it comes down to E&M services. So they were saying for new and established patients, your 99201 to 99215, those are primary care services. Then you have your E&M services in a nursing home or another facility or in the home. So those are your 99304 through 40 and your 99341 through 50. They also added in 3 well-known G codes, the Welcome to Medicare visit. So that's for your new Medicare beneficiaries where they have their Welcome to Medicare, and it's like a wellness exam. And then, of course, the additional wellness visits that were allowed under other legislation. So those are G0402, G0438, and G0439. For a hospital setting, your revenue codes 0521, 0522, 0524, and 0525. Again, they could be in a hospital, federally qualified health centers, rural health centers. Those revenue codes, again, those are generally related to E&M services and wellness visits. Those are going to also be considered primary care services. So with that in mind, you become somewhat worried because, to be honest, the majority of specialists are doing E&M visits. It's not as though, again, under the current regulations that we have, especially under Stark and anti-kickback, that physicians just sit around and make referrals for imaging services. Instead, they're meeting with their patients and they're doing E&M services. So this is, again, the rub that came out and a huge question. So let me get into a little bit more of the FAQ clarification and what the ramifications are. So the first one is that there is an updated Medicare Shared Savings Program FAQ located online. You can go and get it at cms.gov, hit Medicare, then Medicare Fee-for-Service Payment, and then there's a Shared Savings Program link. It's one of the downloads that will be listed on the left-hand side. One of the things, again, going back just briefly, is that, again, primary care, if it's a true primary care physician, needs to be exclusive. They are for one ACO. But this becomes a question of, well, how are they attributed? Why are they attributed? So there's a 2-part test. And one of the reasons, too, that this becomes an interesting aspect on the 2-part test is, remember, under this legislation, Medicare beneficiaries are given autonomy. They can go to any ACO they want, but physicians can't. So it's a very interesting double-edged sword on the Medicare versions. This is not true for all of the other programs. But remember, for safe harbor, anti-kickback, and other Stark implications, If an ACO is designated by Medicare as one of the pioneer ACOs, they don't necessarily have the same level of scrutiny. So that's one of the reasons that this is such a big deal and folks care about it so much. So the two-part test for patient attribution, again, this is in 42 CFR 425.402A. The first question is, who is the beneficiary seeing? So if it is a primary care physician that's affiliated with an ACO, then they're going to go and just double-check it. But this is whether or not there's an actual contractual affiliation with the ACO, and if the PCP's TIN that they're billing under or that group is on record with Medicare. So then the next question is, okay, so they're attributed to this ACO, but really is this beneficiary going to be attributed to the ACO? And this is why it matters. So they're going to go back and they're going to look at the Medicare-covered services for primary care services that is coming from that individual beneficiary. And they're going to see where the plurality of those services are coming from. So if they are affiliated with an ACO and then the plurality of services are coming from that primary care physician that's coming from ACO, let's say ACO 1, guess what? They're going to be, that beneficiary is going to be attributed to that ACO. But that's why that attribution the first time of the physician matters so much. But let's say, again, if they go in and they look at the plurality of primary care services, and they go in and they see another 10 for these primary care services coming from physicians that are attributed to another ACO, and it's 52% of all primary care services. In E&M services, let's say this beneficiary just took a flying leap off of a curb, and mysteriously they broke their leg. It happens all the time. It's amazing how that happens. But they went and saw a lot of orthopods and others while they were working through this. Again, that other ACO with that orthopedic group affiliated with them, that could therefore be the ACO that the beneficiary is attributed, and the orthopods involved in that treatment might end up being held accountable to only being in that one ACO. And so that's the rub. That's the issue. So if the patient doesn't see a primary care physician, just to recap, and let's say, again, it was an orthopod, a cardiologist, somebody else, and they see them for a lot of E&M services that year, the two-part process will still apply, and you may have a specialist that is considered captive to that ACO and affiliated with that ACO. So that's the issue about all of this. So here's the question. Remember, in that two-part process, the first question is the physician affiliated with an ACO? So in the FAQ, the Centers for Medicare and Medicaid Services did clarify that this does not prohibit other contractual types of relationships and the quote-unquote doing business of the ACO. So specialists could consider looking at other types of contractual relationships with ACO. It does not mean that they're an actual true affiliation. Again, the affiliation is defined in regulation. There are sample documents and certain requirements under the contract for those affiliated specialists. But that may be another option. Why might that not be a great option? Well, and this is, again, the practical implications. The issue is really look at the ACOs that are in your community, look at the arrangements, look at the agreements. But the rub is, again, on these contracts is that the safe harbors that have been afforded for shared savings, so again, reimbursement that might happen because you did such a great job of keeping the patient out of the hospital. Again, we could go back to certain types of bone breaks, invasive procedures in cardiology. Keeping the patient out of the hospital is where your shared savings are going to be. But if you go with a non-ACO affiliation, you likely will not be able to participate in the shared savings. Further, there may be other Stark and anti-kickback implications, and there are other state issues as well that might be raised by whatever contractual agreement you set up. So in the end, the implications here and what you all need to think about is whether or not you're actually going to be able to participate with ACOs, whether or not you're going to be able to do affiliations with ACOs if the primary care services, quite honestly, are being defined as being nothing more than E&M services. So that's why this FAQ is such a really, really big deal, and again, one of the reasons that I think this has come out and is causing a lot of heartburn for folks. So with that, I wanted to go ahead and conclude. I actually did not receive any other questions that have come in. So what I want to highlight for all of you is that, again, you can go in on cms.gov, and under Medicare and Medicare Shared Savings Program, there is this updated FAQ. They do update it often, so I do recommend using your source of truth as being the cms.gov website. And also, again, looking to legal counsel as you evaluate whether or not you want to work with ACOs. Again, it's going to be a very interesting go forward related to this FAQ. So I hope that if you enjoyed this presentation, for live participants as you log off, please take a moment to complete our survey so that you can give me better feedback on how I can continue to provide you with quality content. For those of you listening to the podcast, please remember to rate this recording in iTunes. To receive notices about upcoming Give Me a 15-minute programs, please sign up on jensurfoss.com. Thank you for joining me for today's 15-minute education program. This concludes the presentation.